Good afternoon, folks. We're going to give just a few more minutes to let people transition into our room. We'll get started here just shortly. So thank you for joining us this afternoon. We certainly appreciate your time. As we know right now, time is very precious. We'd like to thank KHI for an engaging summit this morning that we've had, and I certainly have enjoyed the morning sessions, and I hope you all have as well. I'm Robin Colonel with the Kentucky Regional Extension Center, one of your presenters this afternoon. As with any of our presentations from the Kentucky Regional Extension Center, we'd like to remind folks that all information provided today is for general information purposes only and in regards to all content today. We do hope that you will engage with us this morning by posing comments and questions in the chat option there below. And we hope to address all the questions at the end of our presentation today. So joining me today is Jessica Ellett and Vance Drakeford. Jessica has 15 years of healthcare experience and is the Quality and Value Team Lead with the Kentucky Regional Extension Center. She guides our team as we advise healthcare leaders on enhancing performance and value-based care models and providing guidance on quality improvement implementation within practices to improve patient outcomes and drive clinical experience. Vance Drakeford has a master's in health information. He's certified in PCMH and PCSP. He has over 13 years in healthcare experience and is a quality improvement advisor with the Kentucky REC for over 7 years. Vance helps practices throughout the Commonwealth with PCMH and PSP certifications, quality improvement, practice transformation, and EHR implementation. And then myself, I'm a mastered prepared nurse, and I work with the Regional Extension Center in the format of a quality improvement and health IT advisor. I have the perspective of nursing management and leadership, along with a lifetime focus in rural health for the Commonwealth, having been a nurse for more than 25 years. So we appreciate your time today as you join us. Just to talk just briefly about the Kentucky Regional Extension Center and the services that we provide. We've been providing services to Kentucky since 2010 with the introduction of the HITECH Act. We are a proud outreach program of UK Healthcare, and our mission is to be the trusted advisor and partner to all healthcare organizations across our state. Our services are listed here, and if you'd like any more information about any of the items there more in detail, please reach out to us using our contact information that will be listed at the end of the presentation today. Our objectives for this afternoon is we're going to talk about specifically quality improvement in healthcare. We will discuss what is quality improvement, why do we need it, how it's used in many of the popular healthcare programs, and then successful examples of successful teams applying quality improvement methods in action to drive performance outcomes. Remember, the quality improvement is a process to improve data, but each data point represents a person. And ultimately, quality improvement helps improve care in people. And that's our goal today, is to help you improve care in your people. Next slide, please. So we wanted to start out with an activity just to engage all of our attendees today. So we hope that in the chat function that you will list or agree or add a few things. We talk about everyday stressors in healthcare. And so we've created this word cloud of things that just add to or contribute or influence the stress that you have as far as practice management and hospital care. So originally we were hoping we could annotate these and let you put stars and hearts and checks and X's across there. But if you don't care, just in the chat, add a few of these things that you see on here that that you agree are stressors for you within your practice. And we'll talk about those as hopefully as we go along today. See a few things popping in there. Interoperability release of COVID information. That is definitely a stressor. we were so looking forward to having an in-person program today, and COVID got in the way. It needs to go back to 2020, I think, let us alone for 2021. Documentation burden, interoperability, integration, correct. Oh, I see a comment in there about physicians and understanding that switch to value-based payment over fee-for-service. That is definitely a struggle, and it does create stress. There is some fear for patients. Absolutely. They're still afraid to come to the clinic versus telehealth visits. And then how do you incorporate telehealth into your practice? This is so good. Thank you all so much for commenting in the chat. I'm not going to tarry too long here so we can get into our presentation. We certainly don't want to take up too much time from our the remainder of our hour, but I appreciate you participating in this activity with us this afternoon. So here now to discuss the quality improvement methodology a little more in depth is Vance Drakeford.
Well, thanks, Robin, and welcome everybody. I'm so glad to have you guys join us today for our session. So we're just going to go ahead. I'm going to start and just dive into what exactly is quality improvement. I know over the past several years, I have studied up on several different definitions of what quality improvement is, and our team has looked through this as well. And I think one of the best definitions that we have found of quality improvement is through the HRSA definition. And they define quality improvement as systematic and continuous actions that lead to measurable improvement in healthcare services and the health status of targeted patient groups. So we really think this is such a fitting definition for quality improvement. And if you really pay attention to those words that are bolded, and think of quality improvement as needing to be systematic and continuous actions, measurable and targeted on different patient groups. If you think about those words, that will really drive what quality improvement should be. Quality improvement really needs to become a habit in your organization in order to really embed this as a fundamental characteristic. And by doing that, you can really create some positive momentum and capitalize on the benefits of doing quality improvement in your practice. So one of the tried and true methodologies for quality improvement, many of you are probably aware of, is that Plan, Do, Study, Act cycle, or the PDSA for short. It's really simple, it's effective. IHI emphasizes this methodology, and it's really one that's easy to use and implement. So that's why we like to use this method when we help our practices, because it has a great impact for driving that improvement across your organization. And a lot of us don't even realize that you're using a PDSA cycle or a quality improvement methodology. It's just almost like a basic instinct that we all have to try to improve something. Plan something out, you put a plan together and you implement it and then see what works. And that's really the basis of this. And I think that's why it works so well, because we do all have that instinct usually to do that. So with the actual methodology though, there are 4 steps. So that's where the PDSA comes from. So the plan is going to be the step that's going to require the most amount of time and planning for an improvement or an intervention. So you want to spend a little bit extra time on what your intervention is going to be, what the plan is going to be, establish your baseline and data, and set some goals and a timeline for what you want to improve. After you do that, you're going to carry that out and implement that. So that would be the do section. You know, start off small. Don't try to do something brand new across your entire organization, because that usually doesn't work too well. Start off very, very small, very simple. And then you want to document everything that you observe from the plan, and make sure you catch all those observations in the data so you can assess that later. Then that third step to the PDSA is the study part. This is where you want to take those observations, assess what you did on that intervention in this plan, see how it worked, what went well, what didn't, and then compare that data to any predictions that you all have made prior to starting this. And finally is the ACT. So here, after you've studied it, you've assessed all the data, you really want to decide at this point, what worked well, what didn't. Do you want to adopt it, adapt it, or abandon this? So, if you adopt something, that's when the test went perfectly, everything was awesome. It made a big difference. So then you want to start that spread and adopt that across your organization. Maybe things went well, but not as well as you wanted them to. So I think that's a perfect time for you to maybe make some revisions and maybe think of things that could make it even better next time. And at that point, that's when you can set those improvements and do a little bit of an adaptation to that original sprint or PDSA. And then of course, abandon. If you do this and it totally bombs, you've learned this is not what you need to do. Completely forget about it the next time. This is not time wasted. It's actually really helpful because you've gained some knowledge that you didn't know beforehand that that you won't have to do in the future, or you shouldn't do in the future. So when you complete that PDSA, you're going to need to track your outcomes. I know working with practices over several years that this is the part that people tend to kind of lack on and forget about. But it's the most important because this is where you're going to document what happened during the test, what worked and what didn't. So when you go to study and compare that, you're going to need to have information in order to make those decisions and adjustments. So it's going to be really important that you track your outcomes. Most people can use some sort of a PDSA form. We're going to show you an example here in just a minute of an example that you could use, but just realize that you're going to make sure you need to track those outcomes. You also want to remember, like I just said, of how important those negative outcomes. They can sometimes tell us as much as those positives because you are continuously wanting to improve. So you've learned something not to redo again, and that doesn't work. Once you do find out those positive outcomes, then it's going to be really important that you take those positive changes and start spreading them across your organization so you can make a bigger impact for your entire patient population. And if you do this, you're just going to generate some more positive outcomes, which will in turn provide more sustainability. So I promised I'd show you a PDSA form. So here's just a brief example of what one can look like, kind of walk through the process. Like I said, you want to start small. Don't try to start with 10 providers and 100 patients. Start with maybe one patient and one provider on one day, and then see how that intervention that you've planned worked. If it worked well, maybe do a couple providers the next day and a couple more patients, etc., and kind of piggyback off of that philosophy until you've gained some experience and you got a broad base of information at your hands that you can spread that to the larger section of your organization until you can finally do that for the entire organization. And you're going to have a lot better buy-in from your staff and from maybe even your patients. So I think that is critical that you start small and kind of progress from that standpoint. Because you're going to find out what didn't work and why. And that's important of tracking those outcomes so you can keep track of that, what's working, what's not, and those specifics. This is not when you want to be too general, because then that vagueness is not going to give you the answers that you're looking for. You really need to start small, keep the intervention simple. So when you go to track that information, you're looking at something specific, and then it's not too broad range, and you really don't know what may have affected that outcome. So make sure that's important as well as you do things in a granular level and being specific. And lastly, what can you do to improve your next PDSA? Well, this is where you're going to decide if you're going to adapt it, adopt it, or abandon. So after all this evaluations of these observations of your data and et cetera, that's when you're going to decide, hey, this is what we need to do. and then plan for that spread. How much bigger are you going to make the next change intervention, or how much smaller? So now that we've kind of defined what quality improvement is, I'm going to pass this on over to Jessica, and she's going to talk to you guys why QI is important.
Hi, thank you so much, Vance. It is great to be here with you all virtually. Really wish we could be in person. And so fingers crossed, hopefully next year. So, I do have practices and clinicians ask me, why do I need to care about, or why do I need to do quality improvement? Why is it important? They say things like, I'm drinking from a fire hose already. I don't have time for this. So whenever that happens, I ask my practices to really kind of step back and think about, first of all, think of some of the payer programs that you're participating in, the reimbursement dollars maybe that get left on the table because of metrics simply just not being met at the end of the quarter or the end of the year, right? So in many cases, that money that's left on the table could actually help cover staff salary to help support the practice and the work that you're trying to do. I also challenge, practices to think about, all of the times they say things like, wouldn't it be even better if, or, there has to be a better way, or how we're doing this just doesn't make sense. And you know what? Quality improvement is what actually gets you there. And it creates a better experience as a provider giving care whenever you're engaged in a process and that you have that ownership. We also want our patients to receive the best evidence-based care possible, because when we become the patient, we expect no less, right? And at the same time, that goes for patient experience. We all want to be treated with compassion and dignity and respect on either side of the exam table. So all of these things that I mentioned to you are really part of IHI's quadruple aim to transform healthcare in the US and really across the world. So improving health of populations, enhancing patient experience and outcomes, reducing the per capita cost of care, and to improve the overall provider experience. Now, when we think about the last 18 months or so in healthcare, it has undoubtedly been an unprecedented time for all of us. And now more than ever, it's critical to focus on improving population health and really addressing issues like chronic disease management to get our populations healthier and stronger. Something else, that is moving forward to the forefront due to the pandemic is really finding ways to connect clinicians and healthcare workers to the joy back into their work. And, as I mentioned, this is a main tenet of the quadruple aim. So, outside of, this public health emergency that we've been in, even in the best of times and in the best performing healthcare organizations, staff burnout is real. And, the research shows that it has an actual direct negative effect on the patient experiences and the patient care for our population. And there's also a correlation too between high levels of staff engagement and high levels of patient engagement and activation to help motivate patients to improve their overall health. This factor of creating a sense of provider and staff engagement really, it creates, an environment where staff are just more likely to be enthusiastic and really, positive about securing the best outcomes for their patients, whenever they feel supported, empowered, and respected. So really focusing on, the tenets of that quadruple aim is why it's important. And it has so many different impacts and influences across patient safety and performance. Quality improvement can help lay the groundwork for successful participation in all sorts of value-based payment models. And really, again, it's just that great way to help engage your clinicians and staff and patients. So now moving on to the next slide, the National Academy of Science, Engineering, and Medicine, formerly the Institute of Medicine, they've identified 4 main principles of a successful quality improvement program to incorporate into any healthcare organization. So the first one, quality improvement should have a defined system and process. So remember back to the HRSA definition of quality improvement that Vance just mentioned a few minutes ago, and the words systematic and continuous actions. So an organization really needs to understand its own delivery systems, mechanisms, key processes that really support it, rather than just, considering it as small or simple or big and complex. There's a lot more nuances and shades in between. So the key to a quality improvement approach, really with any size organization that you're working with, is to really identify your input, your process, and your outputs. So to translate, what this means is you want to define and understand what's going into your system, what processes are in place to support the work happening inside the system. And then the output is simply what's at the end product that's generated by that system. And then just assessing if it meets the desired needs of your organization's healthcare delivery, objectives. So while I'm talking, and I know I'm talking very generic terms about systems and processes, we always have to keep focus that what we do impacts patient lives. And thinking again, referencing back to that HRSA definition, it mentions targeting patient groups and populations, right? So the major concept behind quality improvement in healthcare is to get the patient's needs and expectations aligned, put them on the same page, right? So let's think about some of the services that are designed to bring needs and expectations together. So those can be things like focusing on patient safety, patient engagement, looking at enhancing systems that support patient access, incorporating evidence-based care approaches to the care that's at the bedside, patient-centered communication, factoring in health literacy of patients whenever you're communicating to them. Looking at quality improvement through those lenses can really help keep you focused and centered on that patient experience and aligning it with the quality improvement work you do. The third one is quality improvement should involve a team approach. You want to include staff in order to get higher engagement really and buy-in. And, it all ties into and ultimately impacts and influences what we call coordination of care. So coordination of care is going to be incredibly important, in managing patients with chronic health conditions like asthma, diabetes, heart disease. It's going to help reduce the care fragmentation of a patient by really making sure that that patient feels that they have a trusted, secure network of providers and that there's, a process in place for referrals and smoother transitions of care. The last one is using data to drive improvement. So use only data that's relevant, right? And that you understand. And if you don't understand it, find out what that data means so that that data is actually truly meaningful and that you can use it and apply it. Because data is the cornerstone of quality improvement. You have to know where you've been to look at where you are and to help define where you want to go. Data is going to be able to help you deliver better outcomes, reduce variation, lower readmissions, lower infection rates, reduce medical errors. There's a lot of different uses that we can take our data and apply it to. And we can look at qualitative and quantitative methods to be able to make sure that we get representation of the data that we have. And just remember, there's that saying, what gets measured gets monitored. And then what gets monitored gets fed back. And then what that is fed back can actually be improved upon. So, it's important that we make sure that we keep that cycle going. And then finally, we talked a little bit about those stressors in healthcare, and I appreciate, all the information and the additions that you typed into that box, because, there are so many different things that give us headaches and that keep us up at night, right, in healthcare. And, but there's a lot of things that do give us those headaches that we have control over within our practices, ultimately at the end of the day. And so leveraging the tools and principles behind quality improvement can actually help influence and help make so many of those stressors seem, even just a little bit more manageable. So in the next couple sections, we're actually going to be talking with you all about some of these different areas and how focused quality improvement efforts can lead to significant impacts in care delivery, operations, patient experience, and outcomes. And so with that, I'm actually going to transition it back over to Robin Kernel.
Thanks, Jessica and Vance. So yeah, we're going to talk real quickly about the foundational impacts of quality improvement on a couple of programs that we are all too familiar with. First being hospital promoting interoperability. So just a real quick recap. You know, if you're participating in hospital PI, you have 4 measures that you have to attest to. You have a 90-day reporting period. The scoring is performance-based. You have to meet a minimum threshold. And you're thinking, why do we use quality improvement? Where do we use that in this? We just got to get the numbers right. I mean, I'm sure that's what we all think some days. We just got to get the numbers and then we'll be fine. Well, technically, if you're not meeting the numbers, you're probably putting in some type of intervention in place to get you there. And so that's where we talk about how you're using quality improvement sometimes and don't even realize you're doing it. And you probably use it every day and just not documenting it. So we just want to keep that in mind. You know, this hospital PI program is very strict in that if you don't meet the threshold for points, you don't get payment. And so it's an all or nothing program. So it's very important that you meet those performance measures. So whether you realize it or not, you're using quality improvement in this process. You're reviewing data, you're looking for what's missing, you're instituting interventions, and then you're looking for a change in your outcome based on the interventions that you put in place. We use this one, I think, the most significant with that health information exchange and trying to send and receive summary of cares. So I know that's a headache and a thorn and a stressor that we probably didn't mention earlier. Our next program that we want to talk about is the Quality Payment Program and Medicare's requirement for eligible clinicians to participate in a quality improvement program. And so CMS did that by the MACRA law, where it required CMS to implement some type of incentive program for providers. It moved us away from that OPQRS system. And so now we have quality payment program. And for clinicians, they can participate in one of 2 ways. That program continues to evolve. On the left side of your screen, we have the current process of the quality payment program with 2 different participation tracks. You have those that are in alternative payment models and those who are in the merit-based incentive program system for eligible clinicians. If you participate on the APMs, then you can earn this incentive payment for participating in one of those models, and it's a flat fee by meeting those specific thresholds. If you're on the MIPS track, again, it's performance-based. It's a little different from hospital PI in that it's scalable if you don't meet threshold on what your penalty could be. It's not an all or nothing, but you do have to meet certain requirements in each category. But it's more of a siloed process. We see that CMS is making changes to that siloed process with those 4 different categories to more of a, what they're calling a MIPS value pathway, to where you have a foundational layer, and those are things that you have to do. Regardless of which pathway you choose, everybody's got to work on a population health measure. Everybody's going to work on promoting interoperability. But the remainder of that pyramid is specifically tiered or targeted towards a specific clinical diagnosis, and they're starting out with just 7 right now. So it's less siloed. The quality measures that you focus on under this new value pathway, the improvement activities, your cost measures, they're all around a particular clinical diagnosis. So they're all moving towards a more fluid type of environment. Again, these are performance-based. You're putting in some type of quality improvement methodology around meeting those measures. For some, it's still just a check in the box, but others, it's more meaningful in that it's around a diagnosis group. So what can we do to improve the care for a diabetic population? What can we do to improve the care of our hypertensive population, our COPD folks? Those are value pathways, and where all of the measures that you work for in relation to quality and improvement activities and costs are all directed towards one group. So our next slide, we're going to hear from Vance again. And so I'll let him go ahead and get started.
Thank you, Robin. Appreciate it. So we've been talking about the impacts of QI on different programs. So let's talk now about chronic disease management. I think most of our practices out there deal with chronic disease management. You know, what is that? I think most of us know what that is, but it is that ongoing care to provide that support for individuals living with that chronic disease. You know, there are numerous areas that chronic disease management affect. We can talk about grants, we can talk about regulatory impacts, compliance, readmission rates, clinical outcomes and improvements, and even access. By continually assessing and reviewing and creating improvements in these different areas, then it should really positively impact your patients, your healthcare costs, financial incentives for both federal, state, and other initiatives that you're working on, and really create that strong value-based care program. As we look at this chronic care model that we see here on the right side of the screen, that was actually developed by Dr. Ed Wagner. He was the director of the McCall Institute for Healthcare Innovation. He developed this. So this model is one of the best ways to manage chronic disease. And it really focuses in on 6 fundamental aspects that encourage high quality chronic disease management. So organizations, if you focus on these 6 areas, you're able to develop some productive interactions between your patients. They can help with their self-management care of their own chronic disease, and plus prepare for this value-based care models. So if we want to take a look at these areas, these 6 different areas, and some practical ways that maybe you can make some quality improvement efforts in each of those. If we want to look at start off with self-management support, maybe you could encourage patients with diabetes to attend the DSMES program classes and track their attendance and monitor their outcomes. That would be one way that you could focus on that. If you think about the delivery system design, possibly create some order sets, some workflows within your clinics that patients with chronic conditions receive those evidence-based best practices that are available. And then if you think about decision support, talk about using your EHR. Let that software system help you guys use those CDS rules for workflows, or maybe some different alerts in the EHR that you can do some small tests of change for improvement to help performances on meeting certain measures. Maybe you want to look at doing some sort of quality improvement intervention for colorectal screenings, just show an alert for that, or mammograms, those kind of things that you could kind of put into place and test out. And then if you look at the clinical information systems, that's really looking at the overall, like, to optimize your sharing of information and those transitions of summary care records with your referral partners, and how you can monitor and follow up with your patients post-discharge, and also focusing on that transitional care management and CCM billing codes for that. And then organization of healthcare. This really deals with your leadership, your C-suite, your physician champions. Getting those people on board is really going to be necessary to drive the change that you're going to need in order to be successful. And then lastly, that last of those 6 fundamental aspects here is the community. So you could focus some of your QI efforts on community resources. Maybe you want to look at local health departments, some farmers markets in the area for nutritional counseling with your local health departments as well. Those kind of things that can really help provide some effective change within your patients. So moving on from that chronic disease management and how that is affected by quality improvement, how does quality improvement affect the PCMH and PCSP models? Some of you probably know what that is, what the PCMH and PCSP models are. For those of you that do not, the PCMH is a patient-centered medical home, and PCSP is a patient-centered specialty practice. And these really are just models of care that kind of provide a roadmap to build your practice and help transform it really into a well-oiled machine that includes long-term relationships with your patients, with your providers and your healthcare team. It improves your coordination of care for that referral tracking, those transitional care moments, and it helps to maximize some efficiency. So really getting zoned in on processes and workflows that are all consistent across your organization is going to really maximize that efficiency. And both of these models are embedded with quality improvement that is part of the requirements of the program. So that is embedded in that lower costs from, we've seen from ER use and hospital admissions, as well as patient satisfaction and provider and staff satisfaction as well. These models really prepare practices for value-based care. New England Journal of Medicine, they had an article in their Catalyst journal, and it describes a delivery care model for value-based care as being the PCMH model. NCQA is one of the organizations that has the PCMH and PCSP programs, and they've been really good at embedding quality improvement into their programs that create a strong culture of quality. And by having that strong culture of quality, like we've mentioned here, both Jessica and Robin here, but it really provides a robust team framework, as well as it helps for systems for monitoring for your data and your EHR. It makes you build a quality improvement team if you don't already have one. And also it helps for this coordination of high-risk patients with your those chronic disease patients and your care coordinators and those kind of things to really help with that coordination of care. And as we've mentioned, having that strong culture of quality really can provide some great benefits for your organization and provide that foundation for that value-based care model. And this just reiterates this slide right here is as we look through that QI and what that how that impacts across your organizations. These are just some other things that how workflows for rooming and billing, your overall operations improvement, staff employee engagement, like we've mentioned, and really putting that empowerment within the staff's and providers' hands to make them feel a part of something, and in your patient's hands as well. So it's all overall a functionality of a practice that really builds that quality, that can make quality improvement important. I'm going to transition now back to Jessica, and she's going to talk about some QI in action.
Alrighty, so this is the part I love. Taking the application of these principles and theories and models and just putting it out there in the wild, right? So the first thing we're going to talk about is with the Kentucky REC here. We are in partnership for this particular example for the Diabetes Learning Collaborative with the Centers for Disease Control and the Kentucky Department for Public Health. And we're currently working together to improve outcomes for patients with diabetes across the state of Kentucky. And we've been doing so for several years in a couple different forms. But we've just recently actually launched our second cohort of collaborative participants for this particular initiative. And this is where we have practices from across the state, and they get to meet together either in person, pre-COVID, or now virtually. And we do shared learning, subject matter expertise come together with our practices to deliver evidence-based best practice for the treatment of patients with type 1 and type 2 diabetes. And so over the 12-month time frame of participation in this collaborative, our practices, they test change ideas through that PDSA methodology that Vance talked to you about earlier. And they translate that over to a subset of their particular population of patients with diabetes in their practice. And now once they develop a standard workflow or they achieve their desired outcome around that particular intervention that they're testing, they begin to then scale and spread those changes to other providers, other clinic locations, or just other parts and pieces or areas of their organization for a more wide scale improvement. So the overall aim of this collaborative here is really to lower A1Cs greater than 9. But, we recognize, in treating the whole patient, there are a whole host of other measures and elements that goes into supporting, diabetes best practice, right? So participants rather, I should say, identify what's going to be meaningful to them, to their patients, and really their overall organizational goals. And objectives to really focus on, and pick the interventions and tests of change. So as a result, and you can see from the slide here, put forth, and this is data from our first cohort that ran in 2019 through 2020, there was nearly 7% reduction in the overall volume of patients with A1Cs over 9. So we were able to lower patients' A1Cs across the board in all of our practices. Through this work, over 100% increase in referrals and diabetes self-management education attendance. So this is an education piece, getting patients to feel empowered to manage their care and to learn more about their care and their treatment. And so seeing that being utilized across the state and in areas, there were some areas that hadn't even heard about DSMES. And so this, for the very first time, they were offering this educational outreach opportunity to their patients in their communities. And we also saw a 462% increase in the performance across the entire collaborative of eye exams, and nearly a 200% improvement in the performance of our providers conducting foot exams for our patients. So all of these different elements and even more help to lead the overall improvement in care and health for truly countless patients that were impacted by just this one quality improvement initiative. So I think it's a really neat, interesting project, and it's really fascinating to see just taking a group of people focused and concentrated on one subset of patients, how much they can move the needle by just, taking some focused time to really dig into some of the measures and to dig into their patients and helping to meet their needs. So now with that, I'm actually going to transition over to Vance, who's going to talk with us a little bit about quality improvement with PCMH as well.
Right. Thanks, Jessica. Yeah, and that is exciting with the Diabetes Learning Collaborative, the improvements that we have seen with that. And so now we want to kind of forward to PCMH again and talk about some successes that we have seen recently with this program with one of our clients that just recently submitted for their annual renewal. And within the quality improvement section of that, some of the quality measures and the access patient experience measure that they saw, we saw some great improvement, and we wanted to share that with you all today. But you can see here that the breast cancer screening, they began at a baseline of 43% and moved to 48%. So they saw a 5% improvement. This was after a 90-day, a 3-month time frame. And what they did is they really worked on some PDSAs around messaging to their patients. And that was through their portal and through text platforms. So they used that, did some messaging that way. And within a 3-month period, they did see that amount of increase. So that was some really great work on their part. With their controlling high blood pressure measure, as you can see here, they went up 7%. And what they did for their intervention is they had staff meetings and discussions with their group on their goals that they wanted to achieve, as well as how they were going to use that clinical decision support, those CDS alerts in their EHR. So if their blood pressure of their patients were out of that normal parameters. If they were out of the normal range, then what they did is they gave patients education related to hypertension and discussed that with the patient. That's what they were doing over this 3-month period. And after that, after their remeasurement, they did see the 7% improvement. And then lastly, on their patient experience survey, they really wanted to increase their patient satisfaction scores in regards to the patient wait times that they had. So what they did with their actual staff is they reviewed wait time reports, and they brought that awareness to them to let them know exactly how long, what was that average wait time for patients once they checked in until when they checked out, what was that average time. So when they reviewed that with the staff, then they decided that they would remind patients of how important it was for them to complete the patient satisfaction survey during their visit. And then the registration staff would also monitor patients in the waiting room. And if they had been there 15 minutes or longer, they would make sure that the registration staff would make sure that the medical assistant knew that, so they could follow up on that and get that taken care of in case there was, and fix that, resolve that problem. So after they remeasured in another 3-month period, they saw a huge difference. So they saw 14% change in that. So some great work on this team's part and with some good improvements. But we just wanted to share that with you guys on just using some practical approaches and thinking about some little different interventions that you can try out on different measures and things like that, that you can see quite a big difference. So we were really impressed with this group's work. So now I want to pass this on over to Jessica again, so she can talk about another initiative that we've been working on.
Sure. So, at the REC, we also work with larger multi-specialty organizations, and this one in particular was a large multi-special practice, and they wanted to build a more robust quality improvement infrastructure. So the organization, they implemented a model that partners clinical-based physician leadership with practice managers or nurse managers to help create really a more united and cohesive internal infrastructure that's really focused on improving performance, both around operations-based metrics like access and patient experience, as well as clinical quality measures. So these dyad or triad pairs, they work together with a coach from the Regional Extension Center and then their leadership within the organization to help select areas of improvement that are really meaningful to their particular location or their particular scope of their practice, but then are also impactful to the overall, goals and strategic vision of the organization. So dyads actually, they meet with their internal teams and they plan those PDSA cycles each month. And they also report out through a monthly learning collaborative with their internal peers in other clinical areas, just to help encourage transparency and accountability and just the sharing of data. The example that you actually see on this screen here is a snapshot of data that was taken from what we call a goal group. And so these goal groups are different dyads from different clinical areas, but they're all working together on improving the same goal. And so for this particular example, it's NQF 418, depression screening. So each of these dyads chose different interventions to test in their PDSA cycles throughout the year. And then they meet in those collaboratives to, again, talk about their tests of change. What worked well, what didn't work well, what are they learning from each other on how to improve their overall performance around that measure. And I will say as a great takeaway, it has been fantastic to see, different clinics who perhaps wouldn't normally engage with each other, to see them bond over, shared experiences and to problem solve and work together to help reduce barriers to care delivery, and while also really focusing on improving and standardizing processes around, their patient care and care delivery. So now, moving on to the next slide, as we've talked about, all the different ways that you can use quality improvement to drive change or to really shape the landscape of your practice, I'd like us to consider how to actually get started. That's often the hardest part, which foot to put forward first. I recommend to start by choosing your methodology. It can be lean, it can be PDSA, like what we've talked about, Six Sigma, DMAIC, any other framework that makes sense to you, right? So you want to identify how you're going to measure, how you're going to track, how you're going to monitor your improvements, and how you're going to set yourself and your team up for success and in doing so consistently. The next part is you want to be sure to engage and communicate with your team. your patients, and your peers as you go about implementing any quality improvement process. Sometimes there can be a disconnect between, leadership thinking they know how a process works or goes, but the staff who actually do the job on a daily basis actually are the ones who really truly understand and know the workflows, know all the speed bumps and hiccups that they have to navigate in a day to be able to do their job. So it's important to reach out to those folks to get their input. Also, seeking, patient and family input can also help you identify where to prioritize your efforts as well. Our patients are our end users, and they are often more than willing to help us constructively deliver the best care for them. Overall, after all, when you think about it, they do have a vested interest in your success. Next, you want to create a plan, that's going to work for your team and your organizational priorities. You want to be able to adapt, but you also need to stick with processes to keep things consistent. Remember that it's okay to fail because you will still learn from those failures, and they will help you as you move forward in your tests. In healthcare quality improvement, we fail hard, but we also fail fast. We don't dwell on the failure, we learn from it, and we do no harm. And then lastly, keep it simple. We don't want to overcomplicate or over-engineer something. You want to always check your work by asking, is this too complicated? Are there too many steps? Or does this change actually make sense for us or for our organization? And then finally, you know what? There's no better time to begin improving your workflows for your clinic or your organization, to focus on improving the quality of care or your patient's experience than right now. And we highly recommend and advise that you start today. Start with something small, one patient, one encounter, one interaction, one visit, one clinician, but keep it simple. Ask questions, talk to your staff, talk to your providers, talk to your patients, find out what's important to them, what's working well, what isn't working well. You want to utilize and analyze your data. And, you want to take, even if it's a small step, it's still a step forward. And with that, I'd like to hand the presentation back over to Robin.
Thanks, Jessica and Vance. So again, we're getting close to the end of time. I want to just throw this out there. If you do have questions, you do have a Q&A option there at the bottom of your screen. So just real quickly, how can we at the Regional Extension Center give you some assistance? So we have a host of experts who can provide education and personalized support for you and your team. As I mentioned at the beginning of the broadcast, we strive to be your trusted advisor across the Commonwealth, and we want to help you make change for not only your practice, but more importantly for your patients to help make them successful. So some options that we have quality improvement support and coaching. So if you have a current contract with us, we have an opportunity there that you can just have a contract replacement, and we work with quality payment programs specifically for individualized assistance there. And we also work at the elbow support with PCMH and PCSP. If you want a focus just for quality improvement and maybe establishing a new program within your team, we can provide that as well under a different service with foundational education and providing that individualized assistance to support a specific project. And finally, we've talked about questions here. So I want to just kind of wrap up with a few key statements that I heard. When we talk about using quality improvement, and one of the very first things that we mentioned was joy in the work. It's hard to find joy in work right now. So maybe that's one of your first projects that you tackle. What can we do to find some joy in work? Your data has to be relevant. It has to be meaningful. It has to be useful. If it's not doing what it needs to do, then we need to start very scratch at the building blocks and find out what's going into your data and looking what you need to do to make you confident in your data. You got to measure. If you don't measure and you don't monitor, then you don't know where you're going with. So stick with a plan, as Jessica just mentioned. And by being a plan, let's talk about a plan for improvement. Doesn't mean that you stick with whatever interventions, but you stick with a plan for improvement. You don't give up quickly. It's going to be hard and it might be painful, but honestly, nothing good is easy. So we have to work and we have to be diligent with it. We have to identify quickly whether things are interventions we want to keep, or if we're going to do like Vance mentioned, abandon it. So real quickly, let me look here at our Q&A. Some chat maybe. Talked about our audio quality. It may have dropped off there at the end. Okay, hopefully as it's been recorded, you can come back and pick up on some last few things. Okay, folks, I don't see any questions. We appreciate your time today. We hope that you enjoy the rest of the evening or the afternoon with the Thank you.
Sorry about the audio issues, everyone.
Thank you all. You have a great rest of the conference.